Before the presentation begins, I'd like to give you a little bit of background on Advize Health. At Advize, we analyze processes, implement solutions, and deliver quality educational opportunities to entities of all sizes. Advize has been in existence for over 13 years and employs the industry's top auditing and consulting experts. We offer an extensive catalog of services, including HIPAA and compliance analysis, medical record auditing, and educational opportunities for the healthcare industry. We offer the medical coding and auditing community 30 free CEUs per year through our webinars and coding newsletter. The seminar you're about to view is just one of many services that Advize Health's advisory sector has to offer. We have an incredible speaker today, our very own Melissa Jewett. Ms. Jewett has extensive knowledge on the coding, auditing, and billing industries. With over 16 years of experience performing coding and auditing services for multiple specialties, Ms. Jewett has certainly earned her position as Quality Assurance Specialist and Auditor Supervisor here at Advize Health. Ms. Jewett is a certified professional coder, certified professional medical auditor, and most recently a fellow with the AAPC. Before we begin, I will go over a few housekeeping items. This presentation is worth 1.5 CEUs, which will be sent to all attendees along with a PDF of the presentation, a link to the session recording within 1 to 3 business days. If you have any questions, please submit them to all organizers. We will have a Q&A at the end. I will now turn it over to Melissa to begin the presentation.
Good afternoon. Thank you for attending. Today we're going to be going over auditing for chiropractic services. As Maggie noted, we are Advize Health and we have a full suite of auditing services. And so getting right into the agenda here. We're going to go over these items here: pain in the neck, why are chiropractic services so heavily monitored? We're going to look at chiropractic manipulation and related services, documentation templates, and statuses of conditions, as well as some policies around office visits with chiropractic manipulative therapies, separately identifiable services, and we will talk about billing and documentation trends. So documentation and coding of chiropractic services. What makes chiropractic any different from any other coding and other coding audits? One thing that we've seen over the years is the shift to more mainstream coverage by insurance plans for chiropractic services. And we've also seen where the shift, with the shift of more coverage by insurance plans, then there becomes more plan oversight. And also we see that there's some area where documentation improvements could be added to the community. So why is it monitored so heavily now? Well, it's a lot of money that's going out being paid for these services. According to the Medicare fee-for-service, the improper payment rate was projected at $273.5 million in 2013. So there's a lot of money going out for these services, so of course it's something that's going to be looked at closely. The improper payments for chiropractic services are commonly due to insufficient documentation. There are specific documentation requirements for chiropractic patient visits. Often the following items are missing when we look at the record. Oftentimes we find an adequate description of the service billed, which means that we just see like a CPT code description is listed in the chart versus actually documenting the service itself, the treatment plan, the name of the patient, the date of service, and also commonly we will find that the signature is missing. According to MLN Matters, number SE1101, there's been numerous audits of chiropractic service claims that have found a significant portion of the claims to have been paid inappropriately. Correct claim payment depends largely on providers complying with Medicare requirements for coverage, coding, and documentation services. The goal of this article is to translate published Medicare coverage and payment requirements for chiropractic services into a few practical tips for better Medicare compliance to effectively lower the frequency of improper payments and the corresponding error rate. Technical errors such as missing signatures, dates of service on the claim, not found in the record, etc. In other words, specific documentation that is required as a condition of the payment is often missing from the beneficiary record. Documentation that does not support or substantiate that all of the procedures were performed. For example, no documentation or insufficient documentation that all spinal levels of manipulation were reported and have been performed. No documentation that each manipulation reported related to a relevant spinal area. Insufficient or absent documentation that all procedures or services were medically reasonable and necessary. In other words, the submitted documentation was not sufficient for Medicare auditors to determine whether services furnished were medically necessary. Examples of insufficient or absent documentation for the purpose of determining medical necessity are as follows. Required elements of the history and examination were absent. Treatment plan was absent or insufficient. So here's a stat looking at the Bureau of Labor and Statistics data. Again, this is just showing how prevalent the services are. And here it's talking about the number of cases of people with back and spinal injuries who missed days of work due to the injury. These numbers don't associate to the monetary values, but if we were to consider the 51% error rate for Medicare services and translate that into auto or work accidents, that number could be enormous. So taking a look at why chiropractic services are so heavily monitored, sources of payment, sources of claim submission revenue for all providers. We commonly deal with third-party payers, commercial, Medicare, Medicaid, auto, personal injury, workers' comp. Also, there's a fair share of cash services still because some of these services are paid out of pocket, cosmetic, through wellness programs, alternative healthcare programs. So here is where we kind of get into some of the fraud, waste, and abuse or scheme areas that have been seen recently around chiropractic services, which also adds to why they're heavily being monitored. So tale of two chiropractors practicing in Florida. Both chiropractors were approached with similar scenarios. A non-doctor asked these chiropractors to register a chiropractic clinic in their name with the intention of circumventing Florida law to treat personal injury to patients. A clinic can obtain a certification of exemption if it is owned by a physician. Some facilities have had an illegal or straw physician registered as the owner to circumvent the rigorous certification process. And this is a situation where this Dr. Lisa agreed to put her name on a corporate document, and she was in name-only ownership for these companies. She received a paycheck from the corporations but had no control of the finances or business dealings. And this is something that was talked about at the NHCA conference a year ago quite heavily, where insurance plans could do some trending looking at their files when a provider wants to change, like say for instance, a participating provider wants to change their group name or is registering a change with their NPI or the tax ID number. And one thing that was mentioned during that call to look for these types of instances that could be, you know, a company that's doing this scheme here is adding an MD to a traditional chiropractic office. So if you receive credentialing in your office to add an MD, and the office was traditionally just a chiropractic practice, that may be an alert to look for. And then noticing the trending of the claims and the services that are going out the door for that MD after the credentialing is approved and they start billing. Take a look at the records and who's signing the records, who's actually performing the services. You may be surprised to see that all of those billings are going out under the MD's name, but no services are actually rendered by the MD. Also, another thing that they talked about at the NHCA was looking for names that kind of give like the holistic or wellness idea. So if the chiropractic plan or office is registering a new name or new tax ID number with your health plan, and it's now going to be called Holistic and Wellness Center, one-stop holistic center or something like that that's trying to capture everything, that might be an alert to your company to know that the holistic approach tends to try to wrap in an MD, and then you're going to see an increase of more services being billed, services that chiropractors typically wouldn't bill under their normal suite of services. So this was posted on the FBI website, the OIG's website, regarding this provider that we were talking about on the last screen, and it shows that Mrs. Adams, she did plead guilty, and she faced, 54 months in prison, also to be followed by 3 years of supervised release, and 1.9 million restitution for that scheme. Here's another example of a scheme, a fraud lawsuit where Allstate Insurance, December 11th, 2012, Los Angeles County Superior Court awarded Allstate Insurance Company more than $7 million in a qui tam action filed by the insurer on its behalf and on behalf of the people of the state of California against a Long Beach chiropractor, Dr. Daniel, and his business, Progressive Diagnostic Imaging Incorporated, arising out of a scheme to defraud the insurance company. The judge ordered Dahan to pay Allstate civil monetary penalties. And you'll see that these monetary penalties were quite large here. So in the last several years, MD, DC, and DCPT centers have been highly scrutinized by the various regulatory bodies as well as medical boards and governmental agencies. This page is created to provide a public information and keep you aware of potential pitfalls. Consultants of America is dedicated to help you avoid any mistake. The ethical program is set up to help you develop a successful center using the highest ethics. So this is a great source to look at to avoid these types of fraud schemes in your practice. If you are a chiropractor, or you're considering going into the more holistic avenue for your business, absolutely offering wellness is the focus for quality health care. But just make sure that you've researched and looked at the rules for your state around that. And in terms of the Allstate case that we were talking about, Allstate did win $4 million against the provider here. However, on appeal, it was overturned, and this was a New Jersey clinic. They did file an appeal, and this appeal stated that that the provider didn't knowingly violate the State Insurance Fraud Prevention Act, that he was acting in good faith. So in essence, again, this is the same here, that the provider won on appeal because he was acting in good faith. He sincerely believed it was a correct action, and that was based on guidance given to him by a consultant. So again, just if this is something that you're looking into for your practice, just research the laws, take a look at that, and make sure that you're not violating any rules, unknowingly. So again, this is talking about the plan where a chiropractic practice hires a medical doctor to supervise the physician assistant or advanced practice nurse. Oftentimes you'll find a new TIN or a new NPI created, and or you will find that it's now a multidisciplinary group. Diagnostic services, physical medicine, including injections and DME, may now start being billed by that group once this change was made. And you may or may not see chiropractic services. All right, so moving into the chiropractic manipulations and the coding and documentation around that. When we talk about chiropractic manipulation, what are we exactly talking about? So we are discussing the reduction or correction of a subluxation. A subluxation is a partial dislocation or a slight misalignment of the vertebrae. Subluxations are regarded in chiropractic theory as the cause of many health problems. And here's a list of the most commonly performed services in the chiropractic world. And we'll go through some of these codes more and talk about what the documentation should look like to support these services. But just briefly looking at these here, we've got the chiropractic manipulative treatments, the 98940 through the 98943, and then manual therapy, therapeutic massage, application of modalities, and so on, as well as E&M services, the office visits that go hand in hand with these services, and then taking a look at certain modifiers that come into play, modifiers 25 and 59. So breaking down just the chiropractic manipulative treatment, we often look at these codes, these 4 codes here, 98940, which is the CMT or chiropractic manipulative treatment of 1 to 2 spinal regions. 98941 is 3 to 4 spinal regions, 98942, 5 regions, and 98943, the extra spinal, 1 or more regions. It is important to note here that for the code 98943 that it indicates within the description 1 or more regions, meaning that if there were 2 or more extra spinal regions manipulated, only 1 unit for this code would be billed. You would never have multiple units billed for that code. So here's a nice picture of the 5 spinal regions. The 5 spinal regions are the cervical region, which is your C1 vertebrae through your C7 vertebrae, highlighted in yellow. The thoracic region, T1 through T12, which is in blue. And then the lumbar region, L1 through L5, that is in red. And also at the bottom of the red area there, going into the white area, is the coccygeal or coccyx. Oops, I skipped one. We have the pelvic and sacral region, SI or S1 through S5 joints. Oh boy, not SI. That's a different part of the body. So the pelvic sacral region is S1 through S5 joints. And then we have the tailbone, the coccygeal or coccyx. Taking a look at the extra spinal region, meaning a region that's outside. So when we're talking about chiropractic modalities, that's defined as any physical agent applied to produce therapeutic changes to the biologic tissues, including but not limited to thermal, acoustic, light, mechanical, or electric energy. They can be attended or non-attended. The definition of modalities was added to CPT in 1995 to indicate the different types of services included in this section. To clarify the work performed by the provider, the section is divided into two parts, supervised and constant attendance. Okay, so the differences in the attendance of modality. Modalities can be classified as either supervised or constant attendance. Supervised meaning that the application of the modality does not require direct one-on-one patient contact by the provider. And then constant attendance means that the patient contact is required, direct one-on-one patient contact by the provider. So supervised, not direct contact, constant direct contact. Here we're looking at some of the applications of modalities in chiropractic. We're also starting to see where some of these services may be a component of other related services, such as in the mechanical traction, being a component of manual therapy techniques, which are described with CPT code 97140. So here we have the 97010, the cold packs, 97012, which is a component of the 97140. 97102 is the modality for traction, mechanical traction. 97014, application of modality, one or more areas, electrical stim or e-stim, unattended. 90732, the application of electrical stimulation manual each 15 minutes. So here comes some of the time documentation. And also the application of a modality ultrasound each 15 minutes. All right, for mechanical traction, here's some more information around that. The healthcare provider will apply, actually this is for hot and cold packs, the provider will apply the packs and any physical agent applied to produce therapeutic changes to the biologic tissues. Includes but not limited to the thermal, acoustic, and light and energy. So here's some policy. Medicare states to code is this code is always bundled and will never be paid alone. And then we see Aetna posts online that for CPT code 90710 that it will be denied to all other procedures as it is incidental to overall services provided. And this is the hot and cold packs, the 97010. We also have seen policy for Optum posted in their policy center about this hot and cold pack code 90710, that the payment is considered bundled into the fee for other services. (90712), the mechanical traction of one or more areas. The healthcare provider applies sustained or intermittent mechanical traction, most often to the cervical and or lumbar spine, but it could be to any area of the spine. And the mechanical force produces distraction between the vertebrae or joint, or lengthening between, thereby relieving pain and increasing tissue flexibility. This treatment requires supervision and is typically only one unit is billed per day. However, when multiple separate treatment sessions are performed per day, it is appropriate to report one unit for each treatment session. taking a look at CPT code 97032, the application of a modality, one or more area electrical stimulation each 15 minutes. The healthcare provider applies electrical stimulation to one or more area to promote muscle function and or pain control. This treatment requires direct contact by the provider and can be billed in multiple 15-minute units. So we would expect a note in the chart on direct contact by the provider, as well as the time documentation. There is also some temporary G codes that pertain. If you're doing Medicare billing, you may use the G0283. For the modality of ultrasound, 97035, the healthcare provider applies ultrasound to increase circulation to one or more areas. Here it shows a water bath or some form of ultrasound lotion must be used as a coupling agent to facilitate the procedure. The delivery of a corticosteroid medication via ultrasound is also called phonophoresis and is reported using this code. The medication as a supply may or may not be billed by the payer. This is also a constant attendance code where you would expect to see that in the documentation about the constant attendance, the direct one-on-one constant attendance of the provider, and that would be billed in the 15-minute units, along with the time documentation. The definition of therapeutic procedures was added to CPT in 1995 to clarify the difference between therapeutic procedures, modalities, and tests and measurements. Therapeutic procedures are defined as a manner of effecting change through the application of clinical skills and or services that attempt to improve function. These require direct patient contact. So we'll take a deeper look at these therapeutic services, and we're going to break down each one of these codes and noting what should be documented for each. So looking at the 97110, this is the therapeutic procedure, one or more areas, each 15 minutes of therapeutic exercise to develop strength and endurance, range of motion, and flexibility. The healthcare provider and or patient will perform therapeutic exercises to one or more body areas to develop strength, endurance, and flexibility. This code requires direct contact with a patient or with a healthcare provider and may be billed in 15-minute units. Therapeutic exercise incorporates one parameter, strength, endurance, range of motion, or flexibility to one or more areas of the body. Examples include a treadmill for endurance, isokinetic exercise for range of motion, lumbar stabilization exercises for flexibility, and gymnastic ball for stretching or strengthening. And you would expect to see in the documentation the exercise, the type, and the expected outcome. So if the exercise is for strength building, you would expect to see that documented. Or for endurance, you would notice that that's documented. If the exercise is applied to one body area, for example, knees for range of motion, you would note that the area is documented in the record. For the therapeutic procedure of one or more areas, each 15 minutes, neuromuscular re-education or movement, balance, coordination, kinesthetic, I'm sure I said that wrong, apologies, posture, or proprioception for sitting and or standing activities. So again, notice that this code is a component of the 98940. Commonly, we find both codes billed for the services. 98940 is chiropractic manipulation, and then on the same day, we often see the 97112, which means that it's bundled with. So unless it's supported as a separately identifiable services, typically it is not considered separate. This code requires direct contact with a healthcare provider and may be billed in a 15-minute increment, and you would expect to see documentation of the time for this code as well. Therapeutic procedure, one or more areas, each 15 minutes, including our massage, which may be stroking, compression, or percussion. The provider uses massage to provide muscle relaxation, increase localized circulation, softening of scar tissue, or mobilize mucus secretions in the lung via tapotment and or percussion. This code requires direct contact with the healthcare provider and can be billed in 15-minute units, regardless of the number of body parts treated. In this case, you would expect to see the documentation of time. Also, you would expect to see the type of technique utilized, and the body area is often noted. However, it's not, because this is one or more areas, you would expect to see the body areas noted there. Manual therapy techniques, including manipulation, manual lymphatic drainage, manual traction, one or more regions each 15 minutes. This code is bundled with the 98940 for the chiropractic manipulative treatment. Often we see claims come in where both codes are billed. So commonly they are not separate. This would be an instance where you would have to, the auditor would really look at the record to see what areas, what spinal areas were treated by the CMT service, and then what areas were treated by the manual therapy service. And if the regions or areas do not overlap, then yes, that could be considered separately identifiable. However, if the two areas overlap, if the areas overlap with the two types of services billed, then it's likely to be denied as an unbundling or a component of the 98940. Therapeutic activities, direct, one-on-one, patient contact, use of dynamic activities to improve functional performance each 15 minutes. Dynamic therapeutic activities are designed to achieve improved functional performance, such as lifting, pulling, bending. These activities include the use of multiple parameters such as balance, strength, and range of motion, which are designed to achieve improved functional performance. Examples include lifting stations, closed kinetic chain activity, hand assembly activity, transfers from chair to bed, lying to sitting, and throwing, catching, or swinging. This procedure requires direct one-on-one patient contact by a physician or a therapist and is reported per each 15-minute interval. We would expect to see time documented for the service, as well as the type of activity, as well as the reason for the type of activity. Okay, so taking a look at the E&M services, the office visits, 99201 through 99205 for the new patient services, and then the 99212 through the 99215 for the established visits. Services are reported based on meeting all three key components, which is defined by CPT, history, exam, medical decision-making. New patient visits are defined as those who have not received any professional services from the physician or same specialty and subspecialty within the same group practice within the last 3 years. And we're going to get into more about the E&M codes specific to chiropractors here in a moment. Taking a quick look here at modifier 25 and 59. What substantiates the need for evaluation or CMT in addition to treatment in the same visit? So we're looking at the need for service and then treatment also. Chiropractic manipulative treatment, or CMT, includes evaluation and management of the patient regarding the areas being treated. CPT states a 25 modifier could be appended to the E&M services when another service is provided on the same date is separately identifiable. An AMA CPT manual explains separately identifiable as the patient's condition requires a significant separately identifiable E&M service above and beyond the other service provided or beyond the usual preoperative and postoperative care associated with the procedure that was performed. This might mean a different body area, for example. That's often the easiest way to tell if the visit and the CMT are really separately identifiable. It's gold when you're an auditor and you see separate body areas. That's great. So say, for example, the office visit was for the cervical neck area and the other treatments for the low back. This might mean that the complete or total evaluation of the new patient prior to the decision for treatments being started that day. But we'll also talk about some policies around this as well. So each plan, each carrier has policies around identifying separately identifiable services when it pertains to CMT or chiropractic services. Taking a look at modifier 51, these are separate and distinct procedures, and they would apply according to the CPT assistant. These are separate and distinct procedures, and the use of modifier 51 does not apply. Modifier 51 does not need to be appended to the extra spinal CMT code 98943 when billed in conjunction with the chiropractic manipulative treatment CMT codes 98940 through 98942. Due to the definitive nature of the publication relative to coding of CPT, this means that modifier 51 does not apply, and more importantly, neither does the 50% reduction of payment. So taking a look at documentation and templates, we often find in documentation the status of the chiropractic conditions, and we're going to also look at the chiropractic policies around treatment, around medical and maximum medical improvement, maintenance care, supportive care, separately identifiable services, and other policies for E&M with manipulative treatments. So here is some important current condition keywords, and these definitions are really important as we review the related policies that we're going to get into. And so starting out here, some common keywords that we find looking at chiropractic notes is the word acute. Acute is a new injury, a new onset. An acute condition is expected to resolve with treatment within a short period of time, such as 3 months. Chronic. A patient's condition is considered chronic when it is not expected to significantly improve or be resolved with further treatment, but treatment or therapy can improve functional capacity. Exacerbation. Exacerbation is an acute flare-up of a condition already being treated. And recurrence. Recurrence is a return of symptoms of a previously treated condition that has been quiet for a period of time, such as 30 days or more. Taking a look at the 3 phases of active care in chiropractic treatment. Phase 1, treatment provided is to alleviate pain and is directed to limit the extent of the injury or condition, reduce signs and symptoms of inflammation, and minimize functional disability. The short-term use of the adjunctive therapeutic modalities and procedures may be appropriate in addition to manipulative procedures. If significant improvement in the patient's pain and functional ability is not achieved in the first 2 weeks of care, alternative treatment options should be explored. Phase 2, treatment provided is directed to focus on improving pain-free ranges of motion and restoration of function of the fullest extent possible, promoting structural integrity and avoid deconditioning. Frequency of treatment and use of the therapeutic modalities typically decreases according to the member's progress, and care should be transitioned from passive to active treatments. Phase 3, treatment provided treatment provided is directed to focus on promoting the restoration of strength, endurance, and performance of activities necessary for daily living. Duration and frequency of treatment is variable and is based on the severity and type of the injury and condition, functional limitations, as well as the resolution of the condition or attainment of maximum medical improvement. So maximum medical improvement, MMI, why is that important? Let's take a look at the bottom portion of this slide and what Blue Cross Blue Shield of New Jersey states regarding their policy about MMI. So here we see that in terms of MMI, meeting one of the following criteria would reasonably indicate that the member is at maximum medical improvement, MMI. If the member's condition is asymptomatic and or has reached preclinical status. Chiropractic, orthopedic, neurologic, and range of motion tests performed by the attending chiropractic physician indicate attainment of functional ranges and abilities necessary for usual activities of daily living. When the member fails to make significant functional improvement over a normal, clinically expected time period for the member's condition and or subjective symptoms and objective findings assessed on re-examinations do not meaningfully change. So looking at the record, you would expect to see documentation of the member's condition, especially when they're coming in continually for services. So you would expect to see the status of the condition at each visit, and then noting the functional improvement or status overall, whether it's improving or not improving. So that is definitely something that you would see through the progression of looking at the chart notes. All right, so maintenance care. Oftentimes maintenance care is not a covered benefit by plans. And specifically here, there's policy online that states that this Blue Cross Blue Shield plan considers the continuation of therapeutic treatment once the member has reached a clinical plateau or maximum improvement. It is typically rendered on a regular basis to help maintain optimal body function, and usually is for a chronic condition or after completion of the therapeutic care. Continued treatment after a member has reached a clinical plateau or MMI, resolution and or stabilization of condition, would constitute maintenance type care. This type of treatment is not a covered benefit. So after determining MMI, and then there's continued treatment, you may expect to see a discontinuation of covered benefits. This type of care is considered the continuation of therapeutic treatment once the patient has reached the clinical plateau of maximum improvement. Typically, the patient would go at least 1 to 2 months or more without in-office treatment, and upon re-examination have correlative, objective, and subjective clinical findings compared to previous examination findings. there must be objective clinical evidence of a chronic or permanent condition. Supportive care would be inappropriate if it was interfered with other appropriate primary care or when the risk of supportive care outweighs its benefits. When is supportive care appropriate? It typically is rendered at a reduced frequency of visits, and it is not rendered on a pre-scheduled or routine basis, but in response to symptomatic exacerbations. Supportive care of chronic conditions may not always be reimbursable under the patient's chiropractic benefit. So looking at the record and trying to determine if this is supportive care, the auditors would often be looking at documentation that states that the symptoms have returned, symptoms have worsened, there's an exacerbation of previous condition. So those are clues that you're looking at supportive care. Taking a look at United's policy, which they have posted online regarding chiropractic manipulation, they give an example detailed here within their policy under number 1. The physical exam can identify the items listed. So we'll take a look here under number 1, physical examination. A physical palpatory examination is used to evaluate the musculoskeletal nervous system to identify pain or tenderness evaluated in terms of location, quality, and intensity. You would expect to see those documented, location, quality, and intensity. Asymmetry or a misalignment identified on a sectional or segmental level. Range of motion abnormality, changes in active, passive, and accessory joint movements, resulting in an increase or decrease sectional or segmental mobility, and tissue tone changes in the characteristics of contiguous or associated soft tissues, including skin, fascia, muscle, and ligament. To demonstrate a subluxation based on physical examination, 2 of the 4 criteria mentioned above in number 1 under the physical examination are required. This is excellent. This is excellent policy when you're an auditor because you go back to the physical exam and you see what was really observed, the objective findings in terms of pain, location, quality, the spinal misalignments, and the range of motion. And from that, you can determine the need for the subluxation, the manipulation of those services. Manual devices may be used, but there's no additional payment. So that is United's policy around that. And here we have an example of Medicare's policy requiring documentation of subluxation. So a lot of times we get looking at the records and we don't find any documentation of subluxation or misalignments or anything that would indicate that the patient needed to have the chiropractic manipulation. So again, just like United states that it should be documented in the physical exam, Medicare here has some policy that's similar. So it states that x-rays, as of January 1st, 2000, an x-ray is not required by Medicare to demonstrate a subluxation. However, an x-ray may be used for this purpose if you so choose. The x-ray must have been taken reasonably close to within the time of treatment, which is noted here as 12 months prior or 3 months following. And in certain cases of chronic subluxation, an older x-ray may be accepted if the beneficiary's health record indicates the condition has existed for longer than 12 months. And there is a reasonable basis for concluding that the condition is permanent. A previous CT scan or MRI could be acceptable for evidence of a subluxation. However, it's not necessary to have an x-ray to determine subluxation. Again, we could look at the physical examination. So taking a look at what the doctor observed, the objective findings. To demonstrate a subluxation based on physical examination, 2 of the following 4 criteria should be documented. Pain and tenderness, evaluated in terms of location, quality, and intensity. Asymmetry or misalignment identified on a sectional or segmental level. And then range of motion abnormality. Again, tissue tone changes in terms of characteristics of the contiguous or associated soft tissues, including skin, fascia, muscle, and ligaments. So to warrant or to indicate that there is a subluxation, you could look to the physical examination. And if you find 2 of these items here, then you know that there is a subluxation and you would expect to see the CMT service. So here we get into the maintenance therapy again, and this is United's policy, which explains their definitions as well. You notice that these items have all been linked into the Medicare policy, which is common for most health plans to work from Medicare policy and you know, utilize Medicare policy or work with it and build from it. Again, it talks about maintenance therapy is a treatment plan that seeks to prevent disease, promote health, and prolong and enhance the quality of life. Excuse me. It describes manual manipulation, range of motion, abnormalities, and the subluxation. So once the functional status has remained stable for a given condition without expectation of additional objective clinical improvements, further manipulation treatment is considered maintenance therapy and, according to United's policy, is not covered. Aetna here has a policy that mimics the same, and it gives medical necessity criteria here. Now, note that the last bullet point states once the maximum therapeutic benefit has been achieved, continuing chiropractic care is considered not medically necessary. So all of these policies are really providing a timeline, a progression of, you know, whether the patient is going to improve, whether they've reached their medical max improvement, and then it hits that point of maybe there's you're in a phase of a non-covered service. So some of these policies may entice a provider to not document all of these types of details, which, you know, of course, it wouldn't be good documentation standard, you know, not a good practice. But it does show that, you know, not having that fully documented there could make it a little less understood whether this is maintenance therapy or supportive care. So maybe a little bit of understanding around why documentation has been insufficient as noted by the Medicare improper payment error rates. Again, here we have another policy here from Blue Cross Blue Shield of New Jersey that talks about new patient E&M services and CMT, the chiropractic manipulative therapy or treatment of the spine. So they are eligible for payment with an initial office visit. And in this case, they do require a prior authorization for service. So Medicare coverage overview and chiropractic. Medicare coverage of chiropractic services is specifically limited to treatment by means of manual manipulation of the spine to correct subluxation, that is, by use of the hands. The patient must require treatment by means of manual manipulation of the spine to correct the subluxation, and the manipulative services rendered must have a direct therapeutic relationship to the patient's condition and provide a reasonable expectation of recovery or improvement of function. Additionally, manual devices, such as those that are handheld with the thrust of the force of the device being controlled manually, may be used by the chiropractors in performing manual manipulation of the spine. No additional payment is made available for the use of the device, nor does Medicare recognize any extra charge for the device itself. You would expect to see in the documentation the device, the type of manual manipulation. You would expect to see that documented. Mere statements of diagnosis of pain is not sufficient to support medical necessity for the treatments, as noted on the previous slides. And the precise levels of the subluxations must be specified by the chiropractor to substantiate a claim for manipulation. Again, those levels relating back to one of the earlier slides is talking about like cervical, thoracic, lumbar, those areas, or sacral. Documentation requirements must be placed in the patient's file. Initial visit, the following documentation requirements apply whether the subluxation is demonstrated by x-ray or by physical exam. So we would expect to see in the history the following: symptoms causing the patient to seek treatment, family history if relevant, past health history, general health, prior health, injuries, hospitalizations, surgical history, mechanism of trauma, quality and character of symptoms or problem, onset, duration, intensity, frequency, location, and radiation of symptoms, aggravating or relieving factors, and prior interventions, treatments, medications, and secondary complaints. We would also expect to see a description of the present illness, including mechanism of trauma, quality and character, onset, and this is a repeat of the last slide. The symptoms must bear a direct relationship to the level of subluxation. The subluxation must be causal. The symptoms must be related to the level of the subluxation that has been cited. A statement on the claim that there is pain is insufficient. The location of the pain must describe whether the particular vertebrae listed is capable of producing pain in the determined area. So this is like, you know, getting into a little more of a medical necessity viewpoint. So your RNs on staff in the SIU departments, you know, they could be looking at that, or, you know, a coding RN could be looking at that to know that the vertebral level is or is not responsible for producing pain in the area that's documented in the record. Diagnosis. The primary diagnosis must be subluxation, including the level of subluxation, either so stated or identified by the term descriptive of the subluxation. Such terms may refer either to the condition of the spinal joint involved or to the direction or of position assumed by the particular bone named. The precise level of subluxation must be specified by the chiropractor to substantiate a claim for manipulation of the spine. So we're talking here about the diagnosis specifically, and as it relates to the level. So the level being cervical, lumbar, thoracic, sacral, for example. Treatment plan should include the following: a recommended level of care, which would include duration and frequency of visits, specific treatment goals, objective measures to evaluate treatment effectiveness. Date of the initial treatment should be included in the record so that you can see the progression of the patient's treatment. The patient's medical record should validate all the information on the face of the claim, including the patient's reported diagnosis, physician work, and modifiers. It should verify that all Medicare benefit and medical necessity requirements were met. The MLN Matters article goes on to explain that you should place the modifier AT on a claim when providing active or corrective treatment to treat acute or chronic subluxation. However, the presence of the AT modifier may not in all instances indicate that the service is reasonable and necessary. Maintenance therapy includes services that seek to prevent disease, promote health, and prolong and enhance the quality of life, or maintain or prevent deterioration of the chronic condition, when further clinical improvement cannot reasonably be expected from the continuous ongoing care, and the chiropractic treatment becomes supportive rather than corrective in nature. The treatment is then considered maintenance therapy. The AT modifier must not be placed on the claim when maintenance therapy has been provided. Claims with AT modifiers will be considered as maintenance therapy and denied. Claims without the AT modifier will be considered maintenance therapy and denied. And that would be a specific Medicare rule. So key billing requirements. In addition to other billing requirements explained in the Medicare manuals, it is important that you include the following information on your claim. The primary diagnosis of subluxation, the initial visit or the date of exacerbation of the existing condition, the appropriate CPT code that best describes the service, such as the 89840, 98941, 98942, 98940 being 1 or 2 regions, and then 41 being 3 to 4 regions, and 42 the 5 spinal regions. Extraspinal manipulations. So this extraspinal manipulations are not a covered benefit by Medicare. You will see on the slide that the MLN does educate the reader to associate modifiers GA or GZ, which are Medicare modifiers, HCPC modifiers that explain that it is not a covered, it is an expected non-covered service which relate to the ABN requirement for CMS. Other plans like Horizon, Blue Cross Blue Shield, Aetna, United have different rules around the extraspinal services. According to CPT coding guidelines, chiropractic manipulative therapy codes include pre-manipulation patient assessment. An E&M service may be reported in addition to CMT. If the member's condition requires significant separately identifiable E&M service that is listed above and beyond the usual pre-service and post-service work associated with CMT. Again, keep in mind some of the codes are components of others, such as the 97112 and the 97140, being incidental to some of the CMT services. Clinical justification for administering CMT and specific documentation protocols should be based on the chiropractor's clinical judgment. However, documentation protocols should be for administering CMT to any given area should be recorded in the member's chart on the day of the visit and include the following: a record of the member's subjective complaint, objective physical findings to support manipulation, assessment of change in member condition, and a record of the specific segments manipulated. Clinical documentation must substantiate the need for adjusting specific regions of the spine and its related structures, such as extremities. This must correlate with the member's complaints and health assessment, as well as will the member history, clinical examination, and diagnosis. All records must be legible and understandable. Uniform chiropractic language used within the profession should be utilized in documenting care and treatment. Non-standard abbreviations and indexes should be defined. This is a big area of concern when we get looking at the records. Commonly, auditors find non-uniform language or abbreviations utilized. So taking a look here at some policy around CMT services and E&M, This is a Horizon Blue policy that is posted online. And according to CPT guidelines, CMT codes include a pre-manipulation patient assessment. An E&M service may be reported in addition to the CMT if the member's condition requires a significant separately identifiable E&M service that is above and beyond the usual pre-service and post-service work associated with the CMT. In such instances, the provider should append modifier 25 to the E&M code and ensure that the appropriate documentation is included in the patient's medical record in accordance with CMS guidelines. It is appropriate to separately and additionally report an E&M service only in the following conditions: an initial evaluation of a new member or new condition, or re-evaluation of an established patient's progress under a current treatment plan every 30 days. You would expect to see in the note these items, whether it's a new patient, you would expect to note that that's documented, a new condition, or a re-evaluation with the 30-day marker. Or acute exacerbation of symptoms or significant change in the member's condition, or a distinct and different indication which is separately identifiable and unrelated to the manipulation. It is not appropriate for an E&M service to be routinely reported with CMT. This would be the billing that you see over and over again. CMT service, office visit billed. CMT service, office visit billed. We see that a lot. That happens where modifier 25 is applied to the E&M. And in those cases, it's commonly not separately identifiable. It's either maintenance or supportive care. It's part of the treatment plan to keep coming in for the CMT service. So commonly that is not appropriate to bill that E&M service. Here we have more policy relating to E&M services within the chiropractic. And this is when reporting an E&M service as a separate to CMT for any of the three cited, the provider should append modifier 25. If modifier 25 is not appended, the E&M will not be reimbursed. And of course, this is only if the documentation supports separately identifiable service. An E&M service for a new patient visit is reimbursable once every 3 years according to this policy, and according to most policies, because the 3-year rule applies to new patient visits. An E&M service for an established patient is reimbursable without the need for submission of medical records support one time per every 30-day period within an episode of care. An episode of care is, in context, is defined as a treatment plan under which services are performed to address the same diagnosis by the same provider for a given presenting condition or injury. Other than in the circumstances described above, an E&M service is reimbursable more than once per episode of care only when one or more of the indications in Section 1 above exist and medical records are supported to support it. Level 1 through 5 E&M codes are used to bill for the office visits. We'll notice there's more policy here talking about separately identifiable E&M services in relation to CMT or OMT services. And we find on United Healthcare's website that they post that no E&M service is warranted for previously planned follow-up OMT treatments unless a new condition occurs or the patient's condition has changed substantially, necessitating an overall reassessment. Again, the documentation would show that there's a new condition, a change in the patient's condition, substantial change, and then that would warrant the E&M service and the application of modifier 25. We also find more policy from United Healthcare that talks about treatment guidelines. Treatments, acute or chronic, should generally not exceed 1 to 2 months. And there's more information on what should be documented. Again, focusing on the number of regions to help with the decision making and the type of treatment or intervention. CMS published a national provider signature requirement in April of 2010, and it specifically talks about documenting procedures. Document procedures as soon as possible after performing them and include the code on which the service is based on that documentation. A helpful technique for assuring good documentation is to periodically self-audit claims against records to determine if the codes chosen are supported by the records. Auditing and correcting non-conforming office practices helps minimize claim errors occurring with the clerical task of preparing and submitting the claim. It's helpful for practitioners to use devices to assist manipulations to clearly document the device name and, if necessary, send with records to auditors a device description or other information describing how the device meets CMS requirements for assistive devices. The provider should use terms that are clearly understood to refer to the bone and joint space or position. Documentation of subsequent visits should include linking today's service to the treatment plan that was established, measuring progress towards goals, changes since last visit, exam, evaluation, and discharge when no further progress is notable or foreseeable. When coding for modalities, time, location, and whether or not it's supervised are key components for substantiating the CPT codes. There are many templates that can be found on websites. Oftentimes these are free. Some providers do pay a fee. And unfortunately, not all templates that are available to providers to use to document chiropractic services, not all of them include enough information to substantiate the need for chiropractic services, as we've discussed through these last slides. Here's just a brief view of some templates that are commonly seen. You'll notice the difference here between the left side and the right side having much more specific criteria where the provider could really easily identify the areas where it's C1, 2, 3, 4, 5, and the lumbar areas and the thoracic areas. Very easy to identify those areas, as well as the extra spinal areas, the arms and the legs. And so, the provider on the left side template could identify the same, but there's room to not have it identified as clearly there. So if providers using templates, just be sure, it's a good idea, like the last slide mentioned, to have an auditor, whether internal or external, have an auditor take a look at your records and identify areas of weakness which potentially could cause, claims to be unpaid or claim payment taken back. Here's some more examples around those templates. And this is an example of an appeal letter that is a templated appeal letter that you could, someone posted online that providers could use. And this is it's just troubling because they included the patient and provider's information in them. So this is an example of possibly a PHI risk that was just noted online. Always got to be careful of that. A few examples of commonly used templates can also be found below, and these are just more examples of where you cannot see in the template that it does not indicate, you can see in the template that it does not indicate the body areas being treated or exactly how much time is associated with each. Another example here of what documentation should look like. So documentation should contain information about the patient, including why they were there and the services that were provided to them. Here is an example of a dictated chiropractic report that shows the information that should be included. So here we see that time is documented, 8 minutes of ultrasound. Also, we see areas noted: right anterior shoulder musculature, right subacromial bursa, right bicep tendon. Then we see modality is documented, electrical therapy used, again, time documented. And then area, the body area, lumbosacral musculature, left upper trapeze, and so on. Again, another modality, cryotherapy, again, time documentation, shoulder, right bicep, tendon, muscle. So the areas are documented. That is good documentation to show those items. Here's another example of a treatment note, and let's take a moment to review it. The treatment note today consisted of the following procedures and therapies: E&M office, outpatient established level 2, 10 minutes. CMT spinal 3 to 4 regions was performed using the diversified technique on the spinal joint fixations identified in the musculoskeletal section of the examination. Chiropractic extraspinal manipulation was performed on the patient's right hip. Therapeutic exercises 97110 were performed with active assisted isolated stretching of the affected muscles. 5 minutes bird dog exercise, arm leg, reach hand to knee, 3 sets of 10, and so on. Electrical stimulation for 10 minutes is applied to the low back. So is this a separately identifiable E&M? What regions were included in the CMT? So if we're looking at the CMT documentation, it's the second bullet point of this note. It states that it was performed using diversified technique on the spinal joints and fixations. Fixations is a word that's commonly interchanged with subluxations, which were identified in the musculoskeletal section of the exam. Well, as far as what I see here, I don't have enough information to know what 3 or 4 regions were manipulated. And if you can refer back and see in the exam the areas, then yes, it may be supported. But with this amount of information, the spinal areas are not documented for the CMT service. Okay. So common areas, common red flags that we see when we're looking at chiropractic services is we commonly see E&M codes billed with every patient encounter, routine use of full spine x-rays, billing for new patient visits at a high level E&M code like a 4 or a 5, high incidence of level 4 and 5 established patient visits, high incidence of modifier 25 and 59 utilization, high incidence of billing CMT and manual therapy. We also commonly find when we're looking at records that they're handwritten notes that we cannot read. Or we find incorrect CMT codes were billed versus the number of regions documented. So here, 5 spinal regions were billed when only 4 were supported. Billing for manual therapy when provided at the same time as the CMT. And you'll notice here that the manual therapy overlaps with the same area, cervical spine and thoracic spine, for both manual and CMT services. So this would be a case where we cannot determine that it's separately identifiable. Therefore, the 97140 is a component of the 98941 or 4142. Or 4.3. We also find use of non-standard abbreviations, and then if a provider is audited who utilizes abbreviations, especially non-standard ones, it is recommended that a key is provided to explain the abbreviations to the auditor. EHR templates that do not include treatment as a future plan, or EHR templates that include the treatment as a future plan, but the documentation is not clear as to what was actually performed, meaning the note looks like a treatment plan only, and there's no documentation to really state this was the service that was performed on this date. It often looks like just a plan. However, you would see that the provider bills for the services, the 98940, on this date, so they're using this as justification of the service performed, not only planned. We also find EHR templates that just list the CPT code and the description, the descriptor from CPT, without real documentation of the service performed itself. We find time-based codes with no time documented. We see exercise modalities with no notation of what type of exercise was performed. And we find a pending modifier 59 to procedure codes when there is no NCCI edit. Billing for modalities without documenting the anatomical site or of application of the modalities. For example, the CPT code 97012, traction mechanical. We don't know, according to this record, what site, what area of the body that was applied to. And that concludes today's presentation. We can open it up to Q&A if any questions have come in.
Thank you, Melissa. We have received a few questions. Let me take a look. This one is from a little earlier in the presentation. It says, on the eStim, doesn't the provider just apply the electrodes, start the modality, and leave the room as it is done in physical therapy?
That is a good question. I would have to look it up to see if it's noted as attended or unattended. Let me see if I can go back to that slide quickly. I'm gonna stop showing my screen so you guys don't have to watch me flip through 5 million slides.
In the interim, I'm going to answer a few more housekeeping questions that we've been getting in. The PDF presentation or the slides will be sent out with the CEU certificate in 1 to 3 business days. They will be coming from an Advize Health email, so please make sure that Advize Health is marked as a safe sender. I know sometimes things can get caught up in firewalls. And the CEUs, there will be 1.5 that will be given. So you may expect those, and again, it's very typical with our past webinars, 1.5 CEUs. We are going to record and post this presentation on our YouTube site, which is youtube.com/advizehealth. You will also be able to find our past webinars on there.
Okay, thank you, Maggie. All right, so this is the slide for the eStim, and it says that this is direct contact, which is not the same as constant contact. So you're correct. They put the electrodes on, but direct is not the same as constant. So the provider could leave the room.
Thank you. We have another question here that says, it appears as though we are saying that a chiro can have a new patient visit every 3 years, regardless of whether or not they have been seeing the patient during that time. Is that the case?
Yes, that generally is the rule for all specialties. If you've not seen the patient within 3 years, you can bill a new patient visit again. And that applies to your tax ID if you're in a group. Any provider that participates or bills under that group tax ID. So if it was an associate in your practice that saw the patient once within the last 3 years, then it would not be new to you.
Okay. We have one more question here, so if anybody else has a question, feel free to Send it to all organizers. The question states, shouldn't the 9-7 codes be billed with modifiers such as GT or GO, much like physical or occupational therapy?
Those are Medicare required modifiers, and they may pertain to the modality codes, especially if you are in the physical therapy community. Yes, so take a look at the HCPCS manual and your CMS rules around utilizing the Medicare modifiers.
Okay, great. That appears to be all the questions we've had for today. If you have any further questions, feel free to email info@advizehealth.com. Melissa, do you have any final remarks before we end the session?
No, thank you.
Okay, thank you everyone for joining us. We'll see you next time.